Cephalopelvic disproportion, what you should understand is the terminology used only when there is a cephalic presentation and when there is a kind of disproportion between either the size of the fetal head and the pelvis, or the size of the pelvis, or any abnormal positions which will lead to non-engagement of the head or descent of the fetal head, is what we call it as cephalopelvic disproportion, right? So most of the times what we encounter in the day-to-day practice commonly is that the cephalopelvic disproportion is relative, in the sense the true cephalopelvic disproportion in terms of the discordant sizes of the fetal head or the pelvis is very, very rare. And the contracted pelvis, or the pelvis which will not able to negotiate even a normal sized fetal head, is very, very rare nowadays. But we do encounter them in developing countries, especially when there are severe nutritional deficiencies like vitamin D deficiency, or even any other disorders like poliomyelitis or pelvic disorders, where there is a contracted pelvis and that wouldn't allow even a normal sized head to deliver. So that is actually a true cephalopelvic pelvic contracted pelvis. And even when there is a normal pelvis, sometimes the fetal head is larger. In that case also there is a true CPD. So true CPD, as I told, is quite is not very uncommon, but what is more common is the relative CPD. That means though there is a normal fetal size head, though there is a normal sized pelvis, there is a kind of a disproportion, or what we call it is discordance, where the head will not be able to negotiate through the pelvis. And this occurs because of either a malposition of the fetal head, or a what you call a deflexed head most of the times. So these are the two important conditions where there is a CPD involved, right? So one you have to remember is the CPD can occur at any level of the pelvis. It might occur at the inlet, the mid cavity, or the outlet, but most of the time CPD at the inlet is what is generally termed as the CPD. And one important cardinal moment what we learned in the previous class about the engagement is that the engagement in a vertex presentation, we call it is engaged, or the head is engaged, when the BPD, or the biparietal diameter, has passed through the pelvic inlet, right? So that is what is termed as engagement. And when that occurs, when the BPD of the vertex or the head passes through the plane of the pelvic inlet, this is the plane of the pelvic inlet, what happens is the lowermost portion of the fetal head is at the level of the ischial spines, or that is nothing but the zero station. So this is the ideal position when we call it as the head is engaged, right? So engagement at when there is a CPD at the inlet of the pelvis, then the engagement will not occur. So non-engagement of the head, especially the beginning of the labor or even otherwise, indicates that there could be a CPD in such a patient, and we have to reassess it more properly. So this is about the CPD at the inlet. Next. Now, CPD, as I discussed, can be true or relative. And relative CPD is the most common, is associated with fetal malpositions like occipital posterior position or a brow presentation. Brow presentation occurs when there is a partially deflexed head. So when there is a completely deflexed head, what presentation occurs is the face presentation. So in this picture, you should be able to understand what happens when there is a well-flexed head. When there is a well-flexed head, what happens is the presenting part is the vertex, right? So when you do a PV examination, what you're able to feel is the vertex. So the flexion of the degree of the flexion of the head can be assessed per abdomen by noting the positions of the sinciput and the occiput. Now, in this picture, you can note that sinciput is the most prominent, point, or the prominent point on the anterior or the anterior aspect of the fetal head, and occiput is the most prominent point on the posterior aspect of the fetal head. So the relative positions of the sinciput and occiput by doing a parabdominal examination will help you assess the degree of flexion of the fetal head. So whenever the fetal head is well flexed means the chin of the fetus is almost touching the chest, right? So what happens is the whole of the head is flexed or the neck is completely flexed. So in this well flexed position, when you do an abdominal examination, the sinciput or the forehead near the forehead, the prominent portion of the fetal head near the forehead is felt lower, lower in the sense towards the, if you consider the maternal position, towards the higher position, and the occiput will be the lower position. So this is the position in a well-flexed head. The same, if you can assess in this picture, whenever there is a partially deflexed head, right? So when the partial deflexed head occurs, what happens is there is partial deflection. You can see the sinciput. This is the sinciput and this is the occiput almost at the same plane, in the same line. So that is when what occurs is even you can see the occiput on the lower side and sinciput on slightly on the anterior side. What happens is you can do the you can make out that it will be a brow presentation, right? So when the occiput goes on the higher level and sinciput can be felt at a lower level on abdominal examination, this is the time when you can see that the head is completely deflexed. The occiput is almost touching the back of the baby, and the presenting part will be the face presentation. So this is how, with the help of the level of the assessments of the occiput and the sinciput, you will be able to assess the degree of the flexion of the fetal head, and thereby assess or come to know whether the presenting part is a vertex, as in well-flexed head, or a partially deflexed head, or it's a deflexed head with propresentation, or a completely deflexed head with face presentation, right? Just a moment, I have a call. Yes, students. So we will discuss further. I hope you understood this concept, Shirisha. How to assess the flexion, degree of the flexion of the head with the help of sinciput and occiput. Yes?
Yes, ma'am, I understood, ma'am.
Fine. So proceeding further, another aspect which would affect the engagement of the fetal head and which could lead to CPD is the abnormal position of the fetal head. So you all, you should be able to understand that the most common position of the fetal head in case of vertex presentations is the left occipito anterior. So what happens in left occipito anterior is here you can see in the left occipito anterior. So if you draw the fetal head here, the diamond shaped, this is the triangle shaped posterior frontanelle will be lying in the left posterior quadrant of the maternal pelvis, and the anterior frontanelle will be facing at the and in this direction. So this is the most common position of the fetal head to get engaged and to present, right? So this is the most common position. So from here, what happens is once the engagement occurs, because of the uterine contractions and because of the further flexion of the fetal head, the left occipito-posterior position will be change it to occipito-posterior position. That is another important moment occurring during labor is the internal rotation. So because of the internal rotation, what happens is the fetal position changes from left occipito anterior, and it changes. Most common is left occipito anterior. It changes from left occipito anterior to LOT, and then it comes back to direct occipito posterior, where the posterior frontanelle will be lying just below the maternal sacrum. So this is what the normally occurs in case of a normal labor in a vertex presentation. So what happens in case of abnormal positions, that is left occipito posterior or the left occipito, here actually the positioning is in the reverse order. Most of the times we imagine with the pubis on the upper side. And imagine when the mother is lying in a dorsal position, the patient is lying in the dorsal position. This is the pubis, and if this is the pelvis here, and we divide it like this. This is the anterior, this is the posterior, this is on the right side of the mother, and this is on the left side of the mother. Okay, so here, as I told, this is the left occipito-posterior position with a diamond-shaped anterior frontinale here, and the left occipito-anterior rotation occurs to occipito-direct position. So whenever there is the left occipito-posterior positions or the right occipito-posterior positions, I'll just redraw that once again. So this is just the sacrum here. If you draw the quadrants. So whenever there is, this is the posterior, this is the anterior, right? So whenever there is occipito-posterior positions, most commonly it is the right occipito-posterior position, especially if the pelvis is kind of an android kind of a pelvis. So what happens in the left occipito-posterior, the internal rotation, when it occurs, the movement of the fetal head has to occur in almost more than 90 degrees, right? It has to come from right occipito-posterior to occipito-anterior. So there is a wide angle movement which is required for the fetal head to go into an occipito-anterior position and then deliver normally. So this time required is very, very long, and this will all depend on good uterine contractions as well as an adequate pelvis. Only then will be higher chances that the occipito-posterior position will take a long rotation and come to an occipito-anterior position. So that's how it might give rise to CPD most of the times. And very rarely what happens is when there is an occipito-posterior position, it rotates it rotates in a reverse direction. Internal rotation occurs in a reverse direction where the occiput comes and lies directly posterior, that is occipito-posterior position, and then the delivery will occur by face to pubis mechanism. So I hope you all have read and understood about how the occipito-posterior position is engaged, and then there is a long anterior rotation, or there is a short posterior rotation, and then followed by face to pubis kind of a delivery. You have understood that, Shirisha?
Yes, ma'am.
Right. So whenever there is an occipito-posterior position, because of the longer duration and longer angle of rotation involved, it might lead to CPD, especially when there is inadequate contractions or the pelvis is not very roomy or adequate. So these are two things you should understand. One is the deflexed head and the occipito-posterior positions, which are majorly causes for the CPD. Okay. Next, coming to the partogram. Now, partogram is a very important graph, what we can say, and all the events of the labor are put up in concised form in the partogram, and it is very, very important to monitor the patient, especially in labor in a partogram, and it gives at one glance you'll be able to see all the important events occurring during the labor. All the monitoring of the mother as well as the fetus comes in one glance, and it also helps you to assess the progress of the labor. When do you need to intervene, what methods are there to be intervened, and all the things will be easily available on one sheet of paper. And whatever the partogram is being used now is the WHO standardized partogram, where it has been particularly standardized, and the graphical recordings of each stages of the labor, including the cervical dilatation, descent, and rotation of the fetal head, are all recorded on this sheet. And as I told, the main purpose of the partogram was to avoid prolonged labor and intervene timely, and it will give you an idea as to what intervention is to be done and when is to be done. That's what is more important. So in the partogram, you have to understand that the latent phase of the labor is up to 3 centimeters of dilatation, and more on an average, as we discussed, it's about 8 hours, 8 to 12 hours. So the latent phase of the labor up till 3 centimeters of dilatation is not recorded on the partogram. It only starts once the patient goes into an active phase of labor. So once the patient goes into an active phase of labor with say 4 centimeters of dilatation, you can see in this picture, we draw a line starting from 4 centimeters. This is the cervical dilatation, and this is the time. This is the time, right? So on the y-axis is the cervical dilatation, x-axis is the time. So the cervical dilatation is measured in terms of centimeters, so 1, 2, 3, 4, 5 centimeters up till 10 centimeters is what has been the normal dilatation of the cervix. And then you put up the time on the x-axis from 1, 2, 3, 4, 5, 6, 7, 8 hours. So when you start of the platogram, as I told, it's always started in the active phase of the labor. So once the patient is in the 4 centimeters, you draw a line, straight line from 4 centimeters to 5 centimeters and 6 at the rate of 1 hour dilatation of the cervix every hour. You plot a line that is the alert line. And then after 4 hours of the alert line, that is, you can see the big boxes here, the 1, 2, 3, and 4. After 4 hours of the alert line, a parallel line to the alert line is drawn at the same rate of dilatation cervix from 4 centimeters, and that is called as the action line. So what we know, what are the events which we record in the partogram is what we should learn next. So remember, mainly the partogram is started once the patient is in active phase of labor, that is after 4 centimeters of dilatation. And we have to record the cervical dilatation. First, we have to draw 2 lines, that is from the 4 centimeters, the alert line, and 4 hours later, we draw the action line. So whenever we are plotting the partogram, remember the timing here is noted in terms of 12 hours or the 24 hours format, so that there is no confusion between AM and PM. For example, if the patient is coming at 4 PM and at 4 PM she's at 4 centimeters, you write 1600 hours rather than 4 PM to avoid the confusion between AM and PM, right? So that is the most preferred way of writing the timing of the patient, right? So in the next picture, what you have to understand is here, apart from the cervical graph, the other things which are noted in the partogram is, of course, the patient's details are documented, that is the name, gravida, parity, and the date of admission, type of the timing of the admission, and the fetal heart rate is monitored in terms of the beats per minute. We also monitor what is the kind of the amniotic fluid, what is the molding in case of the patient being in active labor, and cervical graph. The mother's parameters are also recorded in terms of the pulse, BP, and the temperature. All these parameters are recorded. Apart from that, we have the descent of the fetal descent, or the head or the presenting part is noted. That is also recorded, and also the contractions of the uterus as to how many number of contractions, what is the duration of the contractions. All that is being recorded in a single sheet of paper. So labor is considered as normal. What you have to understand, why you have to draw the alert line and action line, is that when you're plotting the graph of the cervix, you have to observe that the patient's graph is always on the left side of the alert line. Left side of the alert line. Once it crosses the alert line, that is the time which indicates that the patient is having some sort of trouble in the labor. Either it is a prolonged labor, either the uterine contractions are not good, or the rate of the cervical dilatation is not good, or there could be some amount of CPD which has to be reassessed, and the patient has to be decided on some intervention, either in the form of giving an oxytocin drip if the contractions are inadequate, or if the cervical dilatation is inadequate, then you reassess if there's any sort of CPD or any problem. So that is when the alert line indicates that there is some intervention necessary for this particular patient. So once the graph, or the cervical status when you're plotting crosses the alert line, that is the time when you have to be very, very vigilant. Look for all the parameters of the mother and the fetus, reassess the progress of the labor in terms of the position, the descent of the fetal head, uterine contractions, everything. And if the patient is somewhere in periphery in such a situation, that is the time when you need to refer the patient. Once the cervical graft crosses the alert line, that is the time when you think that she's not going to progress normally and she might go into a trouble in terms of a surgical procedure required, like cesarean section. And if you do not have the facilities, that is the time or the ideal time you have to refer the patient. So once the cervical graft is crossing the action line, that is the time when you have to immediately intervene, and most of the times the intervention in such cases is usually due to arrest of the cervical dilatation or arrest of the fetal descent, and then you need to do a cesarean section for such a patient. So action line is where you have to immediately act in terms of terminating the labor and doing a cesarean section. Alert line is where you need to be cautious, and either you do some intervention which is going to help her revert her back, her condition into a left side of the alert line, that is she again progresses normally. If she doesn't progress normally in spite of your interventions, and if she's crossing the alert line, that is the time when you need to be very vigilant and either act swiftly, or you need to refer her if you do not have the facilities for further management, right? So this is what you have to understand between alert line and the action line. Did you understand this?
Yes, ma'am.
Fine. So now how do we use is, as I already discussed most of the points of this, the partograph is used to plot the cervical dilatation, the descent of the fetal head, as well as the uterine contractions, and the fetal parameters are FHR, membranes, Likert, and even the molding of the fetal skull. These are all monitored on the graph. So cervical dilatation, as I had discussed, it is represented by X, and it is 1 centimeter per hour. So 24 squares will represent on the horizontal square, on the horizontal scale, the timing. And as I said, the timing should ideally be mentioned in the 24 hours format in terms of 13 after 12 p.m. you have the 13 hours, 14 hours, 15 hours, 16 hours, and so on and so forth, right? Now, the descent of the fetal head, how do you measure is by per abdominal examination most of the times, and you avoid doing the frequent PV examinations during labor, as you all know, except for maybe once in 2 hours, or if the progression is better, is you do it once in 3 to 4 hours as well. So on per abdominal examination is the best way to assess the descent of the fetal head, and it is measured in terms of the fifths of the fingers. So remember, when you're trying to feel the fetal head on the abdomen above the pubic symphysis, if the breadth of the fetal head is equal to your four fingers breadth, then it means that the fetal head is about 4/5 palpable, right? So that is what is the fifth rule of measurement for the fetal descent. So whenever there is an engagement occurring, that means that the biparietal diameter has crossed the pelvic inlet. That means that the fetal head is crossed the pelvic inlet, and the lowest or the lowermost portion of the fetal head is lying at the level of the ischial spines. So the ischial spines, the level of the ischial spines is considered as zero station, okay? And a centimeter above that will be -1, -2, -3, -4, and centimeter below that will be +1, +2, +3, and +4. So when you are assessing the descent of the fetal head, when you're doing a pelvic examination through the PV examination, you will keep the ischial spines as the reference point, as a zero station. So when you're feeling the fetal head above the ischial spines, and then you assess how many centimeters above the ischial spines, then you note it whether it is at -1 station, -2, or -3 station, as I discussed, above the zero station, and +1, +2, +3, that is below the zero station. So this is how you assess on the PV examination and per-abdominal examination by the fifth rule. So the descent of the fetal head is marked by the sign 0 on the partogram, right? And cervical dilatation is marked as an X. So these are the two important parameters what you'll be noting down on the partogram. Now coming to the pain pathway during the labor, which is also very important. The most important pathways include the pelvic splanchnic nerve, which carries to the S1, S2, S3, S4, even the pudendal nerve, as well as L1, L and T12, and sometimes up till T10. So these are the different pathways of the pains during labor. Management of the pain during labor is another important aspect, what you have to learn. Pudendal nerve block is where the pudendal, you can see in this picture, it is given at this point. You have to do feel the ischial spine with the help of your finger vaginally, and then give an anesthetic injection at this level externally. So pudendal nerve, it arises from S2, S3, S4, and therefore pudendal nerve block will block the S2, S3, S4 nerve roots. It is used for perineal analgesia and relaxation. Anesthesia uses 20 ml of 1% lignocaine. The root of the transvaginal and perineal root site is the pudendal nerve, is blocked just at the level at the tip of the ischial spines. Indication is prior to application of forceps or vacuum, or to suture the vaginal lacerations, or even in assisted breech delivery, we can use it. Paracervical block is where the sensory nerve fibers from the uterus fuse bilaterally at 4 o'clock or 6 o'clock to 8 o'clock position around the cervix in the region of the cervicovaginal junction. In paracervical block, 5 to 10 ml of the 1% lidocaine is injected into these areas to interrupt the sensory input from the cervix and uterus. It relieves the pain of the uterine contractions, and since the block is given in the lateral fornix, so it anesthetizes even upper and third of the vagina as well. It is not useful at the time of episiotomy. Remember, it's only useful to help reduce the pain of the uterine contractions. And for the episiotomy, the best one is the local infiltration or the perineal infiltration. What we do is again to be given for the episiotomy. And it has been known to cause fetal bradycardia, and therefore it is not considered safe, and most commonly we do not use it, the paracervical block. The most commonly what we use is the perineal infiltration. So the points to remember here is pudendal nerve block blocks nerve roots from S2, S3, S4. Used for perineal analgesia and relaxation prior to application of vacuum or forceps, and for suturing of vaginal lacerations. Saddle block spinal puncture between L2 and L5 low spinal anesthesia is confined to vagina and perineum, and it is useful in mid-cavity forceps. And remember, mid-cavity forceps is obsolete now in the modern obstetrics. We do not use any kind of higher forceps. What we use is only the outlet forceps, where after the head is on the perineum, after it is past the outlet, is only to facilitate its delivery is what we do or use the outlet forceps. So mid-cavity forceps is not used in the modern obstetrics. Remember that. Now, perineal infiltration useful is for stitching the episiotomy. So these are the important points to remember in the pain analgesia. Epidural block is what is used nowadays, or the epidural analgesia. It is a very routinely used procedure nowadays, and gives a very effective pain relief for the patient, and she's very, very comfortable during the labor, and she's kind of awake to experience the the joy or the delight of the labor, and that's why this is most commonly used method for relief of labor analgesia. And it gives complete relief of pain throughout the labor, and it is very safe and simple method. Advantages of this regional anesthesia is that the patient is awake and can enjoy the birth time. Newborn upper scores are generally good. It doesn't have any much effect on the fetal, the upper score and the breathing pattern. The lowered risk of maternal aspiration. Post-operative pain control is better. For complete analgesia, a block from T10 to S4 dermatomes are needed. And for cesarean delivery, if at all the patient has to be converted to cesarean delivery, we increase the level of the block from T4 to S1. Repeated doses, or what we call it as top-ups, can be given with 4 to 5 ml of 0.5% bupivacaine or 1% lidocaine are used to maintain the analgesia. So this is about the epidural block. Next, epidural analgesia, as a general rule, should be given when labor is well established. Maternal hydration should be adequate. The woman is kept in semilateral position to avoid aortic cable compression. It is specifically beneficial in cases like pregnancy-induced hypertension, breech presentation, twin pregnancy, and preterm labor. Previous cesarean section is not a contraindication. We can use epidural analgesia in such patients with proper monitoring. Epidural analgesia, when used, there is no change in duration of the first stage of the labor. But what is important to remember is the second stage of the labor is slightly prolonged whenever a patient is taking an epidural analgesia. And sometimes there could be poor maternal efforts because of the mother having not able to sense it properly. Because of the poor maternal efforts, the second stage of the labor is prolonged, and sometimes we have to assist with the help of an instrumental delivery like a forceps or ventouse will have to be used to facilitate the delivery in such cases. So that's about epidural analgesia. Contraindications include maternal coagulopathy or anticoagulant therapy, supine hypotension syndrome, hypovolemia, neurological diseases, spinal deformity, and skin infection at the site of injection. These are the contraindications for epidural analgesia. Important complications, what you have to remember is hypotension, which is again due to sympathetic blockade, and therefore the parturient or the mother should be well hydrated beforehand. Pain at the insertion site or the back pain, post-spinal headache. Then there could be an inadvertent administration of the drug in the subarachnoid space leading to total spinal anesthesia, and then in such a case you have to immediately convert it into a cesarean section and shift her to the OT. Sometimes injury to the nerves or convulsions, pyrexia or ineffective analgesia is another complication. We can say a poorly sedated patient. So these are some of the complications of epidural analgesia. So at this point we come to the end of the theoretical points which I had compiled regarding the normal labor. We will now proceed to few of the questions related to these topics. So I will take up one by one question, and Shirisha, are you here?
Yes, ma'am.
Right. So please answer the questions. They're quite simple, and we will discuss it one to one. And I'll take up about 15 questions in the today's class and cover up the rest of them in the next class. I hope you have understood well all the theoretical points related to normal labor. Is there any doubt before we go to the questions?
No, ma'am.
Okay. So here comes the first question. Now, cardinal moments of labor are. So this is in the chronological order of how it occurs normally in a patient. So it's A, B, C, D. A is engagement, descent, flexion, internal rotation, extension, restitution, external rotation, and expulsion. B is engagement, flexion, descent, internal rotation, extension, and expulsion. C is engagement, flexion, descent, external rotation, and expulsion. Or D, it is engagement, extension, internal rotation, external rotation, or expulsion. Which is the right answer?
A, ma'am. Engagement, descent, flexion.
Correct. So A is the right answer, and it involves all the cardinal movements of the mechanism of labor and in the right chronological order which occurs, right? So that is the answer. That's A. That's the right answer. Next, which cardinal movements occur during labor? Flexion, extension, internal rotation, descent, or asynclitism? Remember, this is a PGI question, and more than one answer will be the right answer in such cases. So what are the answers here?
Internal rotation and
Can you be louder, Shirisha?
ma'am, internal rotation and flexion, I think.
Internal rotation and?
Extension.
Yeah.
And flexion.
It's actually all of them. Okay.
All.
It's all of them. Like all the moments do occur during the normal mechanism of labor, is it not? It's flexion, extension, internal rotation also occur, and descent also occurs. So these are what normally occurring the movements. Asynclitism also is a part of sometimes in case of engagement occurring, there could be asynclitic engagements we discussed in the previous class. So all the 5 options are actually the events which might occur even during a normal labor, right? So that's why all the options are the right options in this particular question. Okay.
Okay, ma'am.
Next one. Now, other things what you have to remember, and so many questions are based on this, is that all these points which are compiled are very important points. So I'll just go on reading them, and I want you to remember it properly. The most common presentation is cephalic in 95% of the cases. The most common presenting part within the cephalic presentation is the vertex. In normal labor, the head enters the pelvis more commonly through the transverse diameter, that is 75% of the cases, or oblique diameters in 20% of the cases. That is the second most common. And AP diameter in 5% of the cases, that is at the onset of the labor. The most common position relation of the occiput to the quadrant of the pelvis, as we discussed, is the left occipito transverse, followed by left occipito anterior position. The engaging diameter of the head is the suboccipitobregmatic diameter, that is 9.5 centimeters in case of a well-flexed head and a vertex presentation. That is what you have to remember. In slight deflection, it is the suboccipitofrontal, which is 10 centimeters. Internal rotation of the fetal head occurs at the level of the ischial spines. In a vertex delivery, the baby's head is delivered by extension, whereas in breech, it is born by flexion. Best time of giving episiotomy is after crowning of the head has occurred. So these are the important points to note, and a lot of questions based on these points, right? Now we'll go to the next question. Duration of the latent phase of the labor is affected by early use of conduction anesthesia and sedation, unripe cervix, hypertonic uterine contraction, or preeclampsia. Yes?
Ma'am, last question. Third one. Hello, ma'am.
Yeah, it got muted. So what was the answer? Prolonged latent phase is seen in which
Ma'am,
cases?
third question, ma'am.
Sorry, yeah.
Yes,
Duration of
question.
the latent phase of labor is affected by. What is the answer?
Early use of conduction anesthesia and sedation.
Early use of conduction anesthesia and sedation. Yeah, that is one of the right answers, correct. And any other right answer for this question? Because it's a PGI question.
Unripe cervix.
Unripe cervix, that's very correct. So unripe cervix and the early use of anesthesia, especially when the patient is still in latent phase, are the most causes of affecting the latent phase, whereas not the preeclampsia or hypertonic uterine contractions. Next one. Prolonged latent phase is seen or is in placenta previa, unripe cervix, abruptio placentae, excessive sedation, early epidural analgesia. So again, a PGI.
D, ma'am.
Have similar.
No.
It's a similar question to the previous one.
Yes, ma'am.
So these two options we already had discussed. Unripe cervix and excessive sedation are the two, options, right options for the prolonged latent phase. Any other?
Epidural analgesia, early epidural.
Yeah, early epidural analgesia, correct. So these three are the right options for this question. Okay.
Okay.
Next one. A female at 37 weeks of gestation has mild labor pains for 10 hours and cervix is persistently 1 centimeter dilated but not effaced. What will be the next appropriate management? Sedation and weight, augmentation with oxytocin, cesarean section, or amniotomy?
Sedation and weight.
Yeah, you're absolutely correct. Sedation and weight is the right approach for such a patient. Remember, she's just 37 weeks and she's been in labor pains since 10 hours, they say, but we don't know whether their pains are the true labor pains or the false labor pains. Is it not? And the cervix is hardly 1 centimeter dilated, so you don't go for an amniotomy in such a case. And of course, cesarean section also you do not want to go because she's hardly 1 centimeter and there is no other indication for cesarean section, right? So these two options are ruled out. Now, augmentation with oxytocin, in this case, she's just 37 weeks and no other indication. In that case, we still can wait for some time. And she's just 1 centimeters in dilation. So she's still in the latent phase of the labor, and we do not do augmentation with oxytocin in the latent phase of the labor. We do in the active phase of the labor, is it not? So that's why these three options are ruled out, and what you're having, the right option is a sedation and wait in such cases. So this is what is the right approach. So what happens when you sedate the patient and wait is, if at all she is in the true labor, she will progress at the end of about 8, like, once she's out of the sedation, she will progress and she will go into an active labor. If it is false labor pains, then she will have not, her contractions will subside, her pains will subside, and she'll be more comfortable. So that is what is the right approach in such a case. Next one. 37 weeks preemie with uterine contraction for 10 hours, cervix is 1 centimeter dilated and poorly effaced. The management is cesarean section, amniotomy, oxytocin drip, or sedation and wait. The similar question again. So the answer, yeah, sedation and wait. Okay, as in previous question we discussed, it's the same options and the scenario. Next one. Commonest cause of non-engagement at term in preemie is CPD, hydramnios, bra presentation, or breech.
CPD.
CPD, yes, that's the right answer. See, hydramnios is not very common. What they've asked is the commonest cause, right? So commonest cause in a cephalic presentation most of the times is a CPD only. Whereas hydramnios, bra presentation, and breech are all very rare, and they are not very common. And cephalic presentation being the common one, and in that CPD will be the most common cause for non-engagement of the head at term in primary gravidas. Okay, so that's the answer. Next, what are the other points you have to remember regarding engagement is it is said to occur when the greatest transverse diameter of the presenting part has passed through the pelvic inlet. So this generally applies to any of the presenting parts of the fetus. It could be either the presenting part in case of cephalic presentation could be the vertex, the bro or the face presentations, or it could be the breech presentations, right? So it will apply to any of the presentations. In all cephalic presentations, the greatest transverse diameter is always the biparietal diameter. So once the biparietal diameter crosses the pelvic inlet is when we call that the head as engaged. Engagement occurs in multipara with commencement of labor in the late first stage after rupture of the membranes, and in nullipara during the last few weeks of pregnancy, that is around 38 weeks of gestation. In primaries, the most common cause of non-engagement of term is the deflect head or the occipito-posterior position, which is followed by CPD. So these are the two most common conditions which will lead to CPD, right? So these are the points you need to remember regarding engagement. Now, coming to the next question. True labor pain includes all except painful uterine contractions, short vagina, formation of the bag of waters, progressive descent of presenting part, or cervical dilatation. Yes?
Option B.
Option, sorry, can you read out the answer because I'm unable to
Short
hear.
vagina.
Short vagina, yeah, that's the correct answer because it includes all the things like painful uterine contractions, formation of the bag of waters, progressive descent of the presenting part, as well as cervical dilatation, right? So this is no way concerned to whether it's the labor pain, whether it's a true labor pain or a false labor pain. So that is the right answer for this question. Next one. Sensitivity of uterine musculature is enhanced by progesterone, enhanced by estrogen, is inhibited by estrogen, or enhanced by estrogen and inhibited by progesterone. Which is the right statement here? How will the hormones affect?
Enhanced by estrogen.
Sorry?
Sensitivity of uterine. Enhanced by estrogen, ma'am.
It is enhanced by estrogen, that is correct. Right. So what about the action of the progesterone on the musculature, on the uterine contraction? What is the action of the progesterone? Does it enhance or does it inhibit the uterine action or the contractions?
No, ma'am, I think no effect.
No effect. No. In fact, the progesterone inhibits the uterine activity or sensitivity, or the sensitivity of the uterine musculature is inhibited by the progesterone hormone. That's why whenever there is a preterm labor or there is a possibility of abortion, we give empirically progesterone injections and progesterone therapy to keep the uterine musculature quiet, to keep it quiescent, we do give progesterone as a therapeutic option for especially preterm labor as well as threatened abortions, remember, right? So progesterone has an inhibitory action on the sensitivity of the uterine musculature, and it will to some extent prevent the uterine contractions and the progression of the labor, whereas the reverse is true for the estrogen, that is, it enhances the sensitivity of the uterine musculature and helps in improving the uterine contractions. Okay. Now the elaborated points on this, you can remember what is the effect of estrogen. Estrogen causes marked proliferation of the endometrial stroma and greatly increases the development of endometrial glands. It causes hypertrophy of the myometrium. It stimulates the synthesis of myometrial contractile protein actinomycin through cyclic AMP. That is the basis or the biochemical basis of how the estrogen stimulates or sensitivates, or the sensitivity of the musculature is increased by estrogen. Under the influence of estrogens, the muscles become more active and excitable, and action potentials in the individual fibers become more frequent. The estrogen dominates the uterus, and it is also more sensitive to oxytocin. It makes it more sensitive to oxytocin. So these are the effects of estrogen on the uterus. Now, what about the progesterone? The progesterone, it promotes secretory changes in the uterine endometrium during the later half of the monthly female sexual cycle. Thus, it prepares the uterus for the implantation of the fertilized ovum. It aids the estrogen in myometrial hypertrophy. It increases the toxicity of the glands. It increases the lipid and glycogen deposits. But what is important, consent to labor, is it decreases the frequency and intensity of uterine contractions, thereby helping to prevent expulsion of the implanted ovum, but it increases the amplitude of contraction. So these are the effects of progesterone on the uterine musculature and other important structures of the uterus. Coming to the next question, which is not included in active management of third stage of labor? Uterotonic within 1 minute of delivery, immediate clamping, cutting and ligation of the cord, general massage of the uterus, controlled cord traction. Which is not an important step of active management of third stage of labor?
Immediate clamping and cutting.
Correct. Yeah, that's very correct, because one of the important aspects in active management of third stage of labor when there is a normal pregnancy and when there is no contraindication is we do not clamp the cord immediately. We let go some of the blood into the fetal body, which is helpful for it, and it will prevent further complications in some of the fetuses like anemia and even intraventricular bleeding and all those. So we don't do the clamping immediately in active management. So the answer for this question is B. That's correct. Next one is also similar one, which is not included in active management of third stage of labor to prevent PPH. Direct oxytocin injection after delivery of the shoulder, immediate cutting cord and clamping the cord, prophylactic misoprostol, or controlled and sustained cord traction. So you know the answer here, right? It's again the B, that is immediate cutting and cord clamping is not the part of active management of third stage of labor. So remember, very, very important, active management of third stage of labor, it includes, one is administration of uterotonic soon after the birth. Best is oxytocin followed by misoprostol. Delayed cord clamping, sorry for the mistake here, it's delayed cord clamping. Delivery of the placenta by controlled cord traction and uterine massage. So these are the important steps in active management of third stage of labor. So pain in early labor is limited to dermatomes, T10 to L1, S1 to S3, L4 to L5, or L2 to L3. In early labor, what they want is the early labor. So what is the answer here? Yes?
L2 to L3.
It's not L2 to L3. It's T10 to L1. So during the first phase of labor, that is early labor, the pain is usually which is supplying the dermatomes to T10 to L1. Okay, so later once she goes into the active labor is when the splanchnic nerves get involved, and the dermatomes, that is S1, S3, the sacral dermatomes getting involved in the active phase of labor. So in the early labor, it is just T10 to L1. Okay, just remember this. Next one. Assessment of progress of labor is best done by station of the head, rupture of the membranes, contraction of the uterus, or partogram. So it's actually all of them. But what is the right answer where all of them can be done on this thing? Single sheet is the partogram, is it not? So the answer here is D, partogram. Next. Now Mrs. AR, she's gravida 3 para 1 living 1, a full-term pregnant female, is admitted in labor. On examination, she has uterine contractions 2 in 10 minutes, lasting for 30 to 35 seconds. On per abdominal examination, 3/5 of the head is palpable per abdomen. On pelvic examination, cervix is 4 centimeters dilated, membranes are intact. On repeat examinations 4 hours later, the cervix is 5 centimeters dilated, station is unchanged, and cervicograph remains to the right of the alert line. Which of the following statements is true? The head was engaged at the time of a presentation. Her cervicographical progress is satisfactory. Her cervicographical status suggests intervention. On repeat examination, her cervicograph should have touched the action line. What is the right statement regarding this particular scenario? Read each of the option again and just assess if it is correct.
Ma'am, after reaching action line only we can intervene on action line or alert line?
No, alert line. Once the patient is crossing the alert line is the time when you have to intervene. See, intervention can be either a conservatory intervention in the form of, if at all, based on what the problem is. Okay. For example, if the patient is on the alert line, it shows that the cervical dilatation is not adequate, right? So why is the cervical dilatation not adequate is what you have to assess in that patient. For example, it is because you have assessed and it shows that it is because of inadequate uterine contractions. So in that case, at the alert line, you can still do a conservative intervention like augmenting the patient with the help of an oxytocin drip, seeing that she gets a good adequate contractions, and that will help her cervical dilatation. Okay, so intervention need not actually be only high-end interventions or last interventions like cesarean section. Okay, they can be minor or even conservative interventions like augmenting with oxytocin, or if the patient is like dehydrated or she's having exhaustion, then you treat the patient, and then that will again help to help in progress of the labor again. So these are the interventions which you can do, and the alert line will help you assess that there is some problem, the labor is not going in a proper direction it should have, so there should be some intervention which you can do. That's how it will kind of interpret the partogram, right? Did you understand?
Yes, ma'am.
Yeah, only when the partograph, when you're plotting and the line is falling on the action line. Okay, so when it falls on the action line or beyond that is the time where you do the final intervention, in the sense you terminate the labor and go for a cesarean section and deliver the baby as soon as possible. So action line is indicating that you need to do a surgical intervention, that is a cesarean section. Alert line is where it will give you a indication that there is some mal progression of the labor and you need to do some sort of intervention, which could be a conservative intervention as well. Okay. So accordingly, what would be the answer for this question? She is just increased by 1 centimeter during the 4 hours duration. See, once she's 4 centimeter plus, it indicates that she's in the active phase of the labor, right?
Yes, ma'am.
So once she's in the active phase of labor, she is a third gravida. Remember, she's a multigravida. So what is the rate of the cervical dilatation you should expect in the active phase of the labor? In a multigravida, what is the rate of the cervical dilatation? The average rate? The cervix should dilate by how much in an hour?
2 times the higher, I think.
No, but generally, what is the standard rate which is used or which is mentioned in the books? It is 1.5, right? But 1.5 centimeter, the cervix should dilate every hour. So in that sense, 4 hours she should have actually delivered itself, is it not? But after 4 hours, the
Yes.
cervix is dilated just by 1 centimeter more. From 4 centimeters, she's just gone to 5 centimeters. That means that the progression of the labor is quite slow, is it not?
Yes, ma'am.
Right. So these statement that is her cervicographic progress is satisfactory is definitely not the right option for this one.
Yes,
Okay,
ma'am.
so this is ruled out. So next one is that the first option, the engagement has occurred at the time of presentation. So remember, they've given at the time of presentation, the head is just 3/5 palpable, right? So 3/5 palpable means what is the station of the presenting part? Where do you expect the presenting part to be on pelvic examination? How is the fifth rule and the station, what I have explained to you previously, how will you
And
be able to
minus
correlate?
side.
Now,
-3. -3.
it's -1 or -2. Okay, see, when the head
Okay,
is
ma'am.
engaged, when we call it as, I'll just go back to that picture. When we say that the head is engaged, it means that the biparietal diameter has crossed the pelvic inlet, is it not? So what happens to the lowest or the presenting part of the fetal head? It will come and lie at the level of the zero station or beyond that, right? It will come and lie at 0 or beyond that. So when the head is lying at 0 or +1 station, and that is when we say that the fetal head is engaged. And when we do a per abdominal examination at the same time, what we should be able to feel per abdomen is only 2/5 or 1/5 portion of the fetal head should be felt on per abdominal examination. Okay, so whenever there is an engagement, remember only 2/5 or 1/5 part of the head should be felt per abdominal examination. And when you do a PV examination, it should lie 0 station or beyond that. That is when it indicates that the engagement has occurred, right? Did you get that?
Yes, ma'am.
Okay, so in that case, in this scenario, in the previous question, what they've mentioned is on per abdominal examination, still 3/5 of the head is felt. So when the 3/5 of the head is felt, that means that the fetal head is still not engaged, correct? So this particular statement, that is the first one, the head was engaged at the time of presentation, is also not the correct statement here. So these two options being ruled out, what we're left with the third and the fourth option, that is cervicographical status suggests some intervention. It says yes or no. From 4
Yes.
centimeters, she's dilated only 5 centimeters. So it indicates that she needs some intervention, yes or no?
Yes, ma'am.
Yeah. So this will be the right statement for this question. Now the last one, on repeat examination, her cervicograph should have touched the action line.
No.
Is it a right statement?
No, ma'am.
No, is it not? Because she's still a long
No.
way to go. She's just 5 centimeters
Yes, ma'am.
and she couldn't be touching an action line just with 1 centimeter dilatation of the cervix, right? So this also is a wrong statement. So what is the correct answer for this is that her cervicographical status needs some intervention. Now, if you take up the same thing and try to plot it up on the, the same scenario in this partogram. So you know that the patient has come to you at 4 centimeters dilatation. So say at about 16 hours, that is 4 p.m. she's come to you, right? And she's 4 centimeters dilated. So you then draw the alert line like this, correct? That's the alert line what you have drawn. This is at 16 hours. She was 4 centimeters. So what you expect actually is anything which is drawn, and it should be on the left side of the alert line. So the cervicograph being on the left side of the alert line is always the normal phase of the labor or the normally progressing labor. So anything coming close to the alert line or beyond that in this zone is where you need to be cautious and kind of reassess the labor and intervene whenever necessary. And when it reaches the action line is where you have to go for a cesarean section, right? So this is how it is. Now in this particular scenario, what has been explained, she's at 16 hours, she's 4 centimeters. So ideally, she should be on the left side of the alert line, but after they have done a PV after 4 hours, that means 16 means 17, 18, 19, 20. That means at 8 p.m. when they have done the PV examination, this was at 16 hours, she's still 5 centimeters only, right? So this is 8 p.m. here, and she's just, after 4 hours, she's just 5 centimeters. She's here, right? Very close to action line. So whenever you see that the cervical graph is falling to the right of the alert line is the time when you need to intervene. And that's what we, is the third option that they have mentioned, is that showing that there is some intervention necessary for this patient. So this is how you need to understand. I hope it's clear to you.
Yes, ma'am. Clear, ma'am.
Right. So now coming to the same thing, I had got a picture where it is nicely shown in color, where anything falling left to the alert line is where you have to observe, monitor the patient and see that she's progressing normally. If it falls on the right side of the alert line is where you have to be cautious. You have to assess her again and do any intervention if necessary. And if it's on the action line or beyond that is where you need to do a cesarean section or intervene at the right time. Okay. Now the next question. All of the following are indications for early clamping of the cord except preterm delivery, post-treated pregnancy, birth asphyxia, or maternal diabetes.
Birth asphyxia.
Birth asphyxia, you don't want to clamp the patient immediately?
No.
You want to clamp immediately, is it not in birth asphyxia?
Yes,
Because you want to resuscitate the baby as quickly as possible. So you want to take up the baby immediately either to the resuscitative area or you hand it over to the pediatricians. So you don't want to wait there for clamping the cord. Okay, you have to clamp it immediately when the baby is in asphyxiated state. You don't wait. You have to immediately clamp, cut the cord and hand it over to the pediatrician, or you go and intervene and intubate or resuscitate the baby in case of birth asphyxia. So there you have to intervene, and early cord clamping is important. What else could be the answer? Preterm delivery, of course, we need to clamp early. Yes or no?
Yes, ma'am.
Because you don't want the baby to be having more blood volume there, which would cause the complication. So preterm labor, birth asphyxia, and even maternal diabetes also, you don't want the baby to be overwhelming there, right? So all the three conditions you want to clamp the cord early. So the answer for this question, where you do not do early clamping of the cord, is post-treated pregnancy. Okay. So in case of post-treated pregnancy, the baby is absolutely normal, right? So in such cases, you can go ahead with the normal active management of the third stage of labor, that is delayed cord clamping, can be followed. Yes?
Yes, ma'am.
Okay. So this is actually the end of today's session. I had compiled the number of questions till 15. So there are a few more questions based on the same topic, which I will be able to cover in the next class. So Shirisha, you are the only one who attended this class, maybe because of the timing I had to change. I hope the others will be able to follow it up with the recorded version. And the next class will be covering up the more questions on the same topic. Okay. So any doubt you had in this particular thing?
No, ma'am. Cleared, ma'am, everything.
Okay, fine. So please revise the topic once again so that you'll have better understanding of the next few more questions on this topic. Okay. And I'll see you again the next week, the same routine time. Okay.
Okay, ma'am. Thank you.
Right. Thank you so much. Pulkesh? Pulkesh, you can call off the day and stop the recording.
Yes, madam, I will do that.
Okay, thank you so much.